All right, welcome everyone. Thank you so much for joining us for this webcast, Innovation and Inclusion, Essential Tools to Help and Essential Tools to Improve Diabetes Care and Cost Management, sponsored by Diabetes Leadership Council and JDRF. This webcast has been pre-approved for one HRCI and one SHRM credit, so please be sure to attend the complete webcast in order to receive your credits. You'll receive an email from hr.com within 2 business days that will include your certification information. So during the webcast, if you have questions for any of the presenters, we ask that you submit those in the Q&A in your webinar controls. That way they don't get buried in the chat. On that note, the chat is open for engagement. You can choose everyone from the drop down and all can engage. Be a few poll questions as well. And I think that's all the logistics on my end. It is now my absolute pleasure to turn it over to Jackie LeGrand and George Huntley to get us started.
Thank you, Rhonda, and good afternoon, everybody. And I'm delighted to be here. I'm George Huntley. I'm the CEO of the Diabetes Leadership Council. I'm a patient living with type 1 diabetes for 41 years. Have other family members also with type 1 diabetes. And in my other past life, and I was the former, as of about a month ago, chief financial officer of a professional services firm. In that role, I've been the plan administrator of a self-insured employer-based health plan for over 25 years. So when we talk about plan design, et cetera, I've actually had to be the plan designer and the fiduciary responsible for health plan design. Delighted to have Jackie with us. Jackie, but please introduce yourself and to the group.
I'm Jackie LeGrand. I'm Senior Manager of Health Policy at JDRF. I've worked here for about 7 years now. I've also lived with type 1 diabetes for about 17 years. I was diagnosed in my adulthood, post-college life. So it's sort of a reminder that it's not just a kid's disease, it hits adults too. And adults live with type 1. Children grow into adults with type 1. And just going to give a little background on JDRF. We are a global nonprofit focused on funding research to find a cure to type 1 diabetes. And in the meantime, we focus on improving the lives of those with it. My role here is to improve insurance coverage and ensure access to diabetes treatments and technology.
Super. And I should have said the same about DLC, the Diabetes Leadership Council. We are a patient advocacy organization. All of our board members and founders are leaders of past leaders of national diabetes organizations. All we do is advocacy on behalf of patient affordability, access, care, and we educate legislators as well as employers on what a patient needs. So through this today's session, hopefully we will have a good dialogue on how an employer can help and really reduce risk as we go. We're going to cover 3 basic areas in today's dialogue. One's going to be the state of diabetes care and coverage to kind of ground everybody on what it is and where are we today. We're going to hear from some medical experts in talking about what diabetes is and how to care for it. We're going to talk about marketplace dynamics influencing the costs and today's care levels. And we're going to have a discussion on HR perspectives and plan design things that you can do tangibly within your plans to manage risk and cost. So that's kind of the way this hour will flow. Again, thank you for spending the hour with us. Also, please, as a reminder, put your questions in the Q&A and we will try to get to those as we go. And with that, I'm going to turn it over to Jackie to take the first segment. And thank you all for being here again.
Great. Thanks, George. First, I'm going to give some background and overview of diabetes pretty quickly. Then we'll have 2 great medical professionals joining our panel. If you have any questions, be sure to put them in the chat box. We'll get to those at the end. And so first, I'm just going to set the stage, going over, diabetes is an epidemic in the U.S. 1 in 8 adults in the U.S. are living with it. That the vast majority of those have type 2 diabetes. And overall, approximately 98 million Americans have prediabetes. So they don't yet have full-blown diabetes, but they're at high risk of developing it. It's also important to note that of the people living with diabetes, 5 to 10% are living with type 1. That's autoimmune condition. People cannot produce insulin. And like I stated before, you know, it often hits children, but it hits adults pretty much equally in numbers. And kids with type 1 grow up into adults with type 1. And you know, and specifically, this also can impact not specifically the employee in your office, but the children of your employee. That also can be type 2 as well. So, you know, there's a lot of people in the US that are living with diabetes, and even more of them are at risk of developing it. So diabetes is not only an epidemic, it's chronic and progressive. That means the longer someone lives with it, the greater the chance they'll have one or more expensive, painful, and life-changing complications that you see here. You know, these are really the costs that drive up diabetes care. The day-to-day is not high cost compared to the complications that can come from poorly managed diabetes. The good news is that these complications can be prevented or delayed with well-managed blood sugars, but to have access to the things that you need for good management, you know, is the only way to prevent these complications. You need access to care, you need access to therapies, medications, and devices. So next slide. Diabetes is a huge cost driver. Everyone in the audience likely knows that it's probably one of your biggest cost drivers for your health plans. The cost is really being driven by the complications that I just shared. Insurers report spending 3 times more for a patient with complications than one without. We are spending most of our diabetes healthcare dollars on complications versus management. The good news is, though, is that we have room to improve and lower our overall costs while improving patient care. So I'm sure many of you have seen these images before, but you know, it's really important that people have equal access and equal opportunity to get what they need in their diabetes care. That's essentially, it means leveling the playing field to give everyone equal access to what they need through their health plan. So we're, you know, and we're not saying that health equity and disparities are going to be fully solved through benefit design, but what you can do is provide a foundation for people to get better access to care. Foundation, you know, it's really important to allow people to have access to technologies and medications that they need. This helps reduce the diabetes burden in disproportionately impacted communities, especially and related to cost sharing. That tends to be a big driver in people's access to the right care. So diabetes disparities exist. It really impacts communities of color disproportionately hard. Non-Hispanic Black adults are 56% more likely to develop diabetes than their white counterparts. Native Americans are nearly twice as likely as non-Hispanic white adults to develop diabetes. And what's worse is that these populations tend to have significantly worse health outcomes for a variety of reasons, including many of the social drivers of health. There's some evidence that people of color are more likely to experience explicit bias in the examination room due to being Black or brown, which contributes to their heightened disparities. They're also less likely to have access to newer diabetes technology like CGM or insulin pump, and to receive training on how to use those technologies to their full advantage. It's also important to note that CGM are now the standard of care for all people with type 1 and also for people with type 2 diabetes who are insulin dependent and use insulin. However, you know, people, not everyone receives the same education on these newest technologies, and if you have access to the technology but can't fully use it, it isn't going to be as beneficial as it could be. So as a result, they're more likely to develop expensive complications and end up in the hospital. So the first block says it all. There's 19 million ER visits and 48.6 million inpatient hospital days over a population of 37 million Americans with diabetes. It's a huge number. You know, of course, it's not 19 million people. It's some people to have a few visits per year, and these are hospital days, but these are really the cost drivers in your health plan. You know, but having numbers like this is crazy high. It means that people are not getting the education, medicine, devices that they need to manage their diabetes and not end up in the hospital. And half of these ER visits result in a inpatient hospital stay. we really, need to invest in ways to avoid the ER in the hospital. It's both bad for people's health and it's bad for costs. Patients with diabetes, your employees, their families are not meeting their health goals. And 89% of people are overweight or have obesity, which is a related disease driving the type 2 increase. So diabetes is a self-managed condition. It comes down to every single day, a person has to make decisions on what they need to do. 180 decisions per day for someone with type 1, what to eat, how much insulin to give, how fast to walk home from your event, because you don't know exactly how much carbs you consumed. And many of these are also for people with type 2 diabetes. There are 525,600 minutes in a year. I didn't sing it. Everyone wanted me to sing it, but I'm not going to sing it. But you're really lucky to only get 120 minutes with a healthcare provider, and that's not even guaranteed. So diabetes is 24/7, 365 days a year. There's no way to take a break. You have to keep going every single day. So it's essential that health plans set people up for success versus failure, which will ultimately reduce health plan costs, especially on major medical side hospitalizations. So now that we've talked about diabetes and as an epidemic, it's expensive. It's probably one of your biggest cost drivers now, and it's out of control. So now we're going to hear from a couple of health experts on what it is and how to successfully manage it. So first, I'll introduce Donna Ryan. She's a certified diabetes care and education specialist and holds dual licenses as a registered nurse and registered dietitian. She most recently served as regional director of population health for Ascension Health Sacred Heart Health System on the Gulf Coast and manager of diabetes programs across the U.S. We also have Dr. Desmond Schatz with us. Dr. Schatz is medical director of the Diabetes Center, professor and associate chairman of pediatrics, and director of the Clinical Research Center at the University of Florida. Thanks, both of you, for joining us.
Well, thank you very much, Jackie, for the introduction. And let me say right up front that this is an opportunity for all of you to impact the lives of your employees. And so really, what is diabetes? Really, diabetes results from either an absolute or a relative lack of insulin produced by an organ in your abdomen called the pancreas. And what it does is that it leads to an inability to really convert food into energy. There is no cure yet, but I can assure all of you that we're really working very hard on it. And when sugar cannot be utilized by the body, this leads to all patients feeling very tired. That'll obviously impact their ability to work, very fatigued, may even present with vision problems, or may even present with complications, as Jackie has already described. As has previously been said, that's 40% of Americans and 37 million people who have diabetes, and almost 100 million have pre-diabetes. Really, again, an opportunity to intervene because it does affect so many of their lives. As I said to you, it's either due to an absolute or relative lack of insulin. And insulin is like the key. It's the key to letting blood sugars into, into the cells so that they can produce and use energy. And again, 1 in 3 adults, that's going to be almost all your employees, require insulin every day. And really, only for insulin prescriptions, they can be managed with good again, with good coverage. Again, 95 to 95% are insulin deficient or insulin resistant, which says that allowing them to use insulin, and in fact, potentially other agents in the future, will enable them to get better control of their diabetes.
Great.
Now-
Dr. Schatz, can you talk a little bit more about the link of type 2 with obesity?
Sure. So type 2 diabetes is very much linked to overweight and obesity. And I think you have shown earlier on that close to 90% of all patients with type 2 diabetes are overweight or obese, which has medical definitions, but I think we can all tell who those patients really are. But so therefore, our focus really needs to be on really weight control. Our body needs to be focused on eating the right foods, on education, on exercise. And we clearly do know that the social determinants of health, as has previously been shown, leads to disparities in coverage and outcomes. And I think it's really important for everybody to understand that we now understand that we shouldn't apportion blame to patients who are obese and who develop diabetes, that we really do know that there is a biology behind this, that obesity, just like diabetes, is a biological disease, and therefore also susceptible to intervention with pharmacological agents.
Great. A common thing that we hear here at JDRF is that diabetes is really hard to manage. It's day in, it's day out, it's 24/7. You don't get your birthday off, you don't get Christmas off. You have to do this every single day. People sometimes think that insulin is a cure. It keeps people alive, but it certainly is not a cure. It's an important tool, but it's not the only thing. And also there's a lot of new technologies that we'll talk about in a minute that really have improved lives significantly over the last decade or so. And it's really important to allow access to these devices. But bottom line is that it's really hard. You can't take a break, and there's really a lot of factors that go into this. We're not going to go over them, but I'm going to pass it over to Donna to talk a little bit more about day-to-day management.
Thank you. And your comments are so important that Des, that you made, and Jackie, the number and the difficulty of managing diabetes leading to complications, which leads to quality of life, and then from our employer perspective, the cost of the complications that come from it. So we want to talk about what we control and what we cannot control. There are 42 factors that affect blood glucose, at least 42 factors. And that's the 24 hours a day. So day to day, your blood sugars may not be the same. One day is not the same as the next. And one person's diabetes doesn't behave, if you will, as the next person. So it really is a moving target. Of the factors that we know affect blood glucose, everyone's aware of food. As it relates to blood sugars going too high and too low, but also to the obesity epidemic. And it's not just about carbohydrates or just about one solution. And you can go on Dr. Google and find tons of solutions for diabetes and food. It's about the timing and the content and the quality. And things such as how far apart your meals are, if you're drinking alcohol or caffeine with them. There's a lot of moving targets with food and blood sugars. In particular with medications. If you're taking medications and you're not eating any at a timing that's ideal for the medication, taking your medications causes the blood sugars hopefully to be in normal range, but you need to take them at the right time and the right amount. And at the right frequency. Activity, high intensity exercise, walking causes blood sugars to go up and down, and things that we don't have control over. Those we have somewhat control over, but things like sleep and stress and your hormones, if you're menstrual or you have other hormonal imbalances, puberty. We have smoking. There's a lot of things that tie into blood sugars going up and down, and it's a moving target. If people need help understanding, you can read about it. You can do a Google search, but it's not the same thing as designing or knowing what you can do about that. The factors are there, and what you can do about those factors that meet your personal needs. So it's really key and instrumental to have a core diabetes education, knowledge about what's going on, and then a plan that fits your culture and your lifestyle. I'm a diabetes care and education specialist. There's a lot of us out there. If your health system has diabetes classes with diabetes specialists, nurses, and dietitians, your patients, your associates need access at the time of diagnosis, annually, and anytime that there's a change in their health status, that they become pregnant or they start insulin or they're going to have, they've developed another diagnosis that goes along with it. Diabetes education is prevention. We've got evidence that shows that it can help blood sugars stay closer to normal than if you don't have the education. Education isn't a flyer out the office door, or like I said, Dr. Google, but sitting down in a class or with a one-on-one with someone who can really tailor what the doctor's ordered and what your lifestyle is to help you make the decisions. It's also really important too, as Jackie mentioned, that we give patients access to solutions that come with technology. And we have some wonderful technology that is available, and it should be, and it needs to be available to your associates that have diabetes, especially on insulin, because it's life-changing and it is real-time information that they can make decisions on. It's one thing for Dr. Schatz and I to sit there and tell people, well, you need to take your medicine here and you need to eat this way and you need to take good care of yourself. But continuous glucose monitors, and you may be aware of them, they're a lot in the media now and there's talk about them. They are life-changing. These devices will give real-time feedback on what your blood sugars are doing before you eat, after you eat, while you're sleeping. There's 288 timestamps that the blood sugars are taken versus taking the blood sugar with the meter 5 or 6 times a day, and you only know that one blood sugar. These continuous readings are really like biofeedback, if you will. So if for lunch you have a salad one day and an iced tea, and you see that your blood sugars are staying in a range that you're happy with, let's say 100 to 150, and the next day you go out to, I don't know, Olive Garden and have the breadsticks and you have the dessert and you see your blood sugars are going really high. That kind of information helps patients understand what their choices, how it impacts their blood sugars. And so what you're seeing on these graphs here, that roller coaster, the up and down, that's a 24-hour period. Blood sugars can go down as low as 50 and 70 and or lower, and then up into the 200s. And so that's based on the activity and the food and everything that we talked about. When we put continuous glucose monitors on patients and they see what their blood sugar reactions are to their lifestyle choices, and they start taking, making different decisions on what they're doing, we keep their blood sugars in range. And so it's that time in range. And I want you to think about this is when the blood sugars are really low or really high, meaning less than 50, 70, greater than 250, many times those acute symptoms will put patients in the ER when they pass out or when they're vomiting and they're sick. So those blood sugars up to highs and lows are an indicator of diabetes being unmanaged or out of control. And it translates into healthcare utilization, whether it's an urgent care or an ER. Continuous glucose monitors alarm people, alert people when their blood sugars are going too high or too low. We also know that it's the long-term complications that come from the blood sugars doing the roller coaster. When we keep blood sugars at normal level, we've got 90 to 180 or 150. we have fewer ER visits, fewer hospitalizations, and in the long run, fewer complications. So those complications of dialysis and amputations and all these terrible things you hear with unmanaged diabetes. This small device, compared to the complications, is preventative care, and it is affordable. There's several different companies out there, and patients and physicians and their healthcare team should be able to choose the one that's best for them. They're shareable. The information can be shared with parents for the pediatrics or with their family members for working people and seniors, and with the healthcare professional. It really is state of the art, and it is life-saving, and it is healthcare dollar saving, and it's quality of life, and it goes going back to the productivity of your associates. If they feel good, and you feel better when your blood sugars are in that controlled normal range. You feel better. You feel more like yourself. You'll have more productive employees. So just to recap, education is important, and then this continuous glucose monitor access. There's also the importance of other technology that's out there. So we have insulin pumps. Insulin pumps are devices that provide insulin to people over the day. Every few minutes or so, it will infuse a little bit. And when they connect to that continuous glucose monitor, we're getting closer to that closed loop of that bionic pancreas, which everyone you may have read about, which is really a technology goal that we have, that we'll be able to control blood sugars with technology in the most non-invasive way possible with patients. So there are insulin pumps, and you may have them on your formularies as well as the CGMs, but I want to encourage, and this is why we're here, that your patients, your associates have access to all of them, not just one. Because it's just like picking a Ford. If that's the only car you let anyone that works for you drive, it doesn't meet everybody's needs. So the same thing with insulin pumps and CGM. So the access needs to be to the broadened to the field that is out there, and you will see better outcomes with your associates if you have those. I may have left something out. Des, is there anything in there that you?
No, I think this is just, for me, a very exciting time, Donna. I mean, as you have pointed out, we're really working on getting to an artificial pancreas. So from that perspective, there's a lot of hope and optimism. And then the other point is that, which is what I spend every day of my life doing, in addition to taking care of patients, is working on disease-changing therapies. We're now in an opportunity to perhaps intervene, particularly in relatives of people with type 1, to test new therapies, which will ultimately be aimed at preventing the disease. And with some stem cell therapies, we're also hoping that we're going to be able to change the lives of patients down the road. But in the meantime, it is so important that we focus on ensuring that people are in their healthiest state so that they'll be ready for these, what I would say, life-changing therapies. Thank you.
Great. Thank you, Donna and Dr. Schatz. I just, want to reiterate how important it is that people have access to these technologies, and it's affordable access. As the technology has become more available, we hear more about people not being able to afford the copays on their diabetes supplies. It's not just about insulin, it's about the supplies as well, and cost sharing is really on a lot of people's minds. So, we just want to remind you that that's also part of this, not just access to the various devices, but the cost sharing as well. So just talking about that, we're going to go over to a poll question. The question is open. In a recent study of 571 people with type 2 diabetes, what was the financial impact of using a continuous glucose monitor? So choose one. Was it a net cost of $425 a month, $53 a month, or savings of $53, or savings of $424? So we'll give you a few minutes to make your choice. So going over the results, it looks like 34% of you said it was a net cost to your plan of $424 per month for people using a CGM. The next most common choice was the net savings of $424 per month at 28% of people. With that guess, net savings of $53 a month from 21% of you, and a net cost of $53 a month from 17% of you. So as you can see, the number one choice was the net cost. But in reality, it's the net savings, $424 per month. And this was almost completely driven by reduced inpatient hospital costs that are caught by the continuous glucose monitor before people need hospitalization. So after this poll, we're now going to turn it back over to George, and he's going to go into some of the more details about plan design.
Thank you, Jackie, and thank you, Des and Donna, for sharing your expertise this morning and this afternoon, wherever you might be. But thank you for your time today and getting us level set as to what is diabetes, why is it so hard. It is hopefully what came across. It's not the patient's fault. It is not just eating right and avoiding that cake and ice cream at the birthday party. This is a very difficult, challenging disease to live with, and there is no day off. And so the best thing that can happen is to make it something where the patient can afford to adhere to therapy. Adherence to therapy is key. So let's talk a little bit about why are things so expensive? Why are we even having these conversations? And we understand that the price of drugs, and let's talk about medicinal therapy, pharmaceutical therapy right now. Insulin is the poster child drug out there. And so I share this slide to show what has happened with the cost of insulin over the decade of 2012 to 2021. And guess what? That this trajectory continues. Over that period of time, the list price, which is that dark blue line, went up 143%. But the net price of the drug, which is the cost to your health plan, the cost that you as plan administrators and running an employer-based plan, the net cost you're paying has cut more than in half. So the pharmacy benefit manager is charging a rebate to the manufacturer to get access to your plan formulary. And that rebate just gets higher and higher and higher as they go through this negotiation in order to get what is now exclusive access to your formulary. And what's happening is the manufacturer is just adding that to the list price of the drug. So the list price goes up, so I can afford to pay a huge rebate. And the net price is in fact much lower than it was a decade ago, but the patients are all too often paying this list price. Now, in this case of insulin rebates are over 70% very often. And on all branded drugs, because this is not just insulin, it's not just diabetes, guys, the average rebate's 48%. So the patient is paying literally double what the plan is paying during their deductible period if you're not passing rebates through the point of sale. So I'm getting right into a plan design issue here, where, why is it so expensive? What's been going on here? The answer here is rebates have really ballooned over this past decade as the pharmacy benefit managers have leaned on them more and more and more to get access to the formulary. So I want to share, this, we call this the hairball slide. And if this was live, I'd ask if anybody has any questions, but I will walk us through how this works, because following the money, and it's always about the money, is really what's important here. So the consumer is your employee, the plan participant. That consumer is paying a premium to you, as the employer, or the insurance company as the health plan, to get access to the health plan. So they're paying a premium. In my mind, they're paying a premium to join Sam's Club. They've joined Sam's Club because they like Sam's Club's pricing. They get access to doctors, they get access to drugs, but when it comes to drugs, they're not getting Sam's Club pricing. They are getting access to the doctors, and they're getting the discounts for the hospitals and the doctors and the labs, but they're not getting any of the discounts with regard to drugs until they've met their deductible. It's the only part of the health plan where that happens. So the consumer, your employee is paying you guys a premium for access to be in the club. Then it's January, and so in January they go to the pharmacy and they need insulin. So they need a vial of insulin is going to retail around $300 plus or minus $25. So let's say it's $300. And by the way, guys, we need 3, or sometimes in the case of type 2s that have high insulin resistance, it can be 5 or 6 vials. So 3 vials of insulin for a type 1 at $300 is $900. I did that math in my head. I hope you all are impressed. But the net cost of that drug to the health plan is $50. So the consumer has paid $900, and forgetting the pharmacy in the middle, but they do actually take a piece of this and they get paid for the drug. But that $900 effectively is going down to the drug company. But the drug company is hanging on to $50 and is sending $250 per vial over to the pharmacy benefit manager. So your employee has spent $900 in January. They watched the ball drop, Happy New Year. And of their $900, $750 of it made its way over to the PBM. The pharmacy benefit manager, you're talking about Express Scripts, CVS Caremark, Optum Rx are the 3 big ones. I've got a slide on that in a second. But they are getting $750 of that transaction. They are keeping an unknown piece of that, but anecdotally, roughly 10 points. We know that from the state of Texas and some of the transparency laws that have been put in place at the state level to require PBMs to describe how much it is they're keeping. And then they are sending the balance of it up to the health plan. Now, if you're self-insured, like I was in my career, that $750 went to the company, or it went to the health plan, if it's fully insured plan. So your employee in January bought 3 vials of insulin, and the company just made a $750 windfall profit. And hopefully you're scratching your heads by that, but that is exactly what is going on in the United States today. And that is most likely what's going on in many of your health plans, if not the vast majority of your health plans today. You are now saying, I'm going to use this money to reduce the premiums. So this sack of money and the insurance premiums is lower. We're going to keep everybody's insurance down, everybody's premiums down. And the issue that I have with that, and that we have, as patient advocates have with that, is the sick should not be subsidizing the healthy. It is perfectly fine for the rebates to be keeping everybody's premiums down when the rebates are post-deductible and people are paying their co-pays, and a lot of rebate money is flowing through the system in that regard. Those rebates absolutely should be used to lower everybody's health premiums. But during the deductible, when your employees and plan participants are paying list price, that should not be held for ransom, if you will, and that should not be lowering everybody else's health plan costs. You got to look at your plan design. And where does the money go? This is, everybody, they own each other. So Optum Rx is a wholly owned subsidiary of United Healthcare. CVS Caremark is in the Aetna family. Express Scripts is in the Cigna family. So you look at this, these 3 have 85% of the US drug market for pharmacy benefit managers. And so the relationships get blurred. By the way, they also own their own specialty pharmacies, et cetera. So when you get into specialty drugs that force your people to go to a specialty pharmacy, they're getting blocked out of the pharmacy down the road. They're getting blocked out in some cases, forcing them into the pharmacies that these PBMs make more money off of. And let's be clear, this is all about them making more money. This is not about you saving money. So your benefit structure determines access here. All 3 of these are very, very common scenarios. You're in a predictable copay, you bypass first dollar coverage, the bypasses the deductible, $25. That's where we advocate you to be, especially with the cost of insulin. If you're passing rebates through at point of sale, in many cases, you're gonna be paying $360 a month. If you're paying a co-insurance or with rebate at point of sale, that's a much lower cost than $1,200. In this instance, we've got 4 vials, but nobody can afford $1,200. Very few people can afford $1,200 a month. We know that 69% of patients abandon their prescription at the point of sale if it costs more than $250. Your people with type 1 diabetes are going to get insulin because if we don't get insulin, we die. But the people with type 2 diabetes who should be on insulin are going to leave that at the pharmacy counter, not take their insulin, and have out of control blood sugars. That's where your largest plan risk really lies. Adding it to the preventative drug list reduces overall complication days substantially. It reduces the complication days specifically for lower income patients by over 10%. This is a big deal, should be a big deal for your plans to consider. One of the questions that we frequently get is, will sharing rebates drive up the cost of my health plan? Is it going to drive up premiums, back to that sack of money? And the answer is no, it won't. We have an actuarial study that said it's 0.4 to 0.6%. That's rounding error on a plan, depending upon the plan type. That study, very in particular, did not take into account having healthier patients. So that has no savings factored in to avoiding the complications. That's just the cost of passing those rebates through. Some key things to think about. Drugs are 10 to 15% of a health plan. It's the tail wagging the dog. The point of pharmacological therapy is to avoid the hospitalization, is to avoid the complications. But 10 to 15%, adding rebates on a small portion only while they're in their deductible, cannot have really a material impact on the cost of a health plan overall, because the health plan overall is driven largely by the major medical stuff, the complications. The other piece is, the only thing I've been living with type 1 for 40 some years. The only thing I can tell you about a chronic disease patient, not just type 1 diabetes, we are going to meet our deductible 100% of the time. If you overcharge that individual for their drugs, congratulations, you are going to pay another claim that you otherwise would not have paid. There is no savings, there's nothing, it's a complete wash, but you've trained the patient to ration their drugs. You've trained the ones that can't afford it easily to not adhere to their therapy. So you've taken a high risk profiled person on your plan, and you've increased their risk profile by not passing these drugs, the drug rebates through at point of sale, again, just during the deductible. Very important thing for folks to understand. It's a myth that patient money is having a material impact on the plan. What it is materially increasing the risk of the plan. So I want to move us quickly to a poll question. Does your organization offer at least one plan with full rebate pass-through to members? Are you doing this today? More and more are starting to. We've been having this conversation for a little while. So yes, no, and you may not know. You may not. This may be a new thing for you. You may be hitting you relatively cold on it. So appreciate your participation in this. Maybe you're all flipping a coin. Is it yes? Is it no? Is it not sure? But I appreciate you playing along so we can see, where are we today in 2024 with our health plan designs. And while I'll continue to do some voiceover while people are checking the boxes, one of the things that we do is we go to lawmakers at the state level and federal level and advocate for rebate pass-through. We actually have this as the law in the state of Indiana, the state of Arkansas, and the state of West Virginia. Some of you may not be aware of that, but it is actually state law in those 3 states. If you have a state adjudicated plan, which many of us on this call are going to be federal ERISA plans, so that law may not technically be required of you. Okay, here we go. So the answer, and this is not surprising, 13%, yes, are in fact passing rebates through at point of sale. 34% are not passing rebates through at point of sale, and 53% don't know. And that is not surprised, but that's why we're having this chat, because I urge you to find out. And we're going to talk in a second about the employer's role in this and the employer's risk in not actually understanding what's going on in the health plan. I appreciate your answers to this. The pharmacy benefit manager, the PBM, has some very perverse incentives, and they are not in your best interest. They're not in the patient's best interest, and they're driving some really bizarre behavior in the marketplace. This slide is indicative of some bizarre behavior, and I'm going to just take the first row at the top here of Humalog and insulin Lispro. Humalog is made by Eli Lilly. It's a brand short-acting insulin drug. Insulin Lispro is a generic biosimilar of Humalog. Why? And normally I cannot say it's a generic. In a biologic drug like insulin, you can't technically have a generic. You can only have a biosimilar. But in this instance, it is in fact a generic because it's the same drug. Eli Lilly makes insulin Lispro. They came out with a generic of their own branded drug. Now, on what planet does it make sense for a manufacturer to create a generic of their own product? That doesn't happen anywhere else out there. Typically, something goes off patent and a generic competitor comes in, but you don't see the original manufacturer coming out with a generic. Why did they do that? Well, thank you for asking. Why they did that was so that they could actually offer the drug at a lower list price. So they can offer insulin Lispro at $82 versus $275 for Humalog, because by their contracts with the PBMs, they can't sell Humalog for less as the branded drug. Novolog has the same situation. This is Novo Nordisk. Novo Nordisk makes this insulin aspart, and they also make Relion. This is the same drug. These are going through the same manufacturing plant, going into the same vial, and they're slapping a different label on it so that they can sell it at different price points and avoid and bypass the contracts they have with the PBMs. This is bizarre, folks. This is a bizarre behavior inside of a manufacturing world. It is not what you would typically expect to see. Generics and biosimilars don't always win. That low-cost drug isn't always on your plan. Now, this is some Medicare Part D data that I'm showing you here, and it's a little pre-pandemic, but it is still pretty true. New generics launched are not getting put on the plan. You think a new lower-cost drug is being offered, hallelujah, welcome to the party, put them immediately on the formulary, let everybody save money. That's not what's happening. They're only 1 in 4 being covered in the first year. Less than half of them are being put on the generic tier on your plans. And I say this, you say, oh, this is Medicare Part D. The same PBMs are the PBMs driving Medicare Part D plans as the one driving your commercial plans. I assure you they're behaving in exactly the same way. I just don't have that data from a commercial plan level, but we do have it from the government plans. So less than half are on so there's zero incentive for your people to take the generic or lower cost drug. They're driving everybody to the high cost drug because that's where the rebate is. They make more money off of the rebate. Over the last decade, the generic tier coverage of generics went from 93 to 45%. That should speak volumes. That should wake us up that our vendor, the pharmacy benefit manager, is not necessarily acting in our best interest, nor are they acting in our participants' best interest. CVS Caremark is currently being sued by by a whistleblower for preventing access to generic medications. In addition to this, in February of this year, Johnson & Johnson was subject to a class action lawsuit, not by a user of their drugs, but by their employee base. This class action lawsuit by their employees is suing the company and their heads of HR, the folks on this call, personally, as for breach of fiduciary duty. And they are claiming under the ERISA law, just like 401k plans, there is a ERISA duty of care and of diligence to maintain and manage costs and manage your vendors. They're getting sued in this lawsuit, not access to lower cost medications, not passing through rebates, using a third-party consultant, which we all use them, that has a conflict of interest because your third-party consultant, many of them are getting a commission from a pharmacy benefit manager for throwing them their way. You may not be aware of this. This lawsuit, it could change the marketplace, and this is going on as we speak. This lawsuit dropped in February, and I believe this is the first of potentially several class action suits aimed at probably larger employers for breach of fiduciary duty with regard to a ERISA-based plan. I do urge you to pay attention to this and watch this as time goes on. It's forcing, it would force things to, most of the conversations and things we're talking about here, it's because it's costing patients a lot of money. It's frankly also costing you a lot of money. I want to talk a bit about obesity care, where as we get closer to the top of the hour here. You heard Des Schatz talk about obesity is it's a disease. We need to go from blame to biology here. Our advocation here is to cover the spectrum of obesity care to give the patient a fighting chance at beating this disease. Diet alone has proven to not work. The vast majority of dieters regain their weight. And there's a reason for that. The body fights for its set point, the highest point that it gets to. The body wants to get back to there, and it's sending you all of the signals to get back to the highest weight point. These new biologics that are on the GLP-1s that are on the market today help reset that, help train the brain from a satiety perspective. And these are hormone replacement drugs. So the bad news of hormone replacement drugs is you got to take them forever. It's like blood pressure medicine, statins, etc. You need to be on these medications pretty much forever. You should be expecting to do that. If you get blood pressure medicine, your blood pressure gets under control, you don't stop taking the blood pressure medicine because you know it's going to go right back up. The same is the best science that we have on this says the same thing is true with regard to obesity and weight loss drugs. But your plans will pay for gastric bypass, but you're not paying for the therapies to avoid that very expensive and very invasive surgery. And urge you to think about that, including behavioral therapies. We talked about the importance of diabetes education. Medical nutrition is really important. Medical nutritional therapy, behavioral therapy is really important. You will probably give as many smoking cessation classes as you can, or as your people want, because you understand how expensive smoking is and how bad that is for your plan and for your people. But you probably aren't covering medical nutritional therapy. Please look at your plan design and see if that's the case. In many cases, you're not covering it today. I'd be surprised if many of you, I'm not even going to ask, I know you're all going to say you're not sure, but I would urge you to take a look at it because I'm going to guess very strongly that you're not. We know that investing in diabetes management pays off. Express Scripts themselves says, if you capped medications at $25, and that's not just insulin, guys, that's everything. Every diabetes medication across the spectrum, you cap it at $25, the total cost of diabetes drops 16.3%. If I just led with that, guys, if I told you I could help you drop your diabetes cost by 16.3%, by the way, it's almost 1 in 4 of your healthcare dollars, you would have gladly stood up in line. That should have been the first slide we put on this deck. That's what it's going to take. You have to allow the patient to adhere to therapy. There's a study on high deductible health plans that was released by JAMA, the Journal of American Medical Association, in February of this year. So this is new information with regard to high deductible health plans. They are increasing complication risks extraordinarily. And why? It's because drug and adherence to therapy is expensive in a high deductible health plan, but it does not need to be. If you are watching and looking at your plan design to make sure that the things that a chronic disease patient needs are actually covered at an affordable copay, then this risk will reduce along with it. And so you can see what you're doing potentially in this. We now have it in black and white. We have studies on it. JAMA is about as reputable a publication as exists in this country today. Urge you to really take a strong look at what copays you're putting on here. Penny wise and pound foolish plan design is going to cost you money. It's just the bottom line of it. We know that 1 in 4 people with insulin have been rationing their drugs. 70% of this, which is not on this slide, but 70% of those folks are below the age of 65. They're on your plans. This is happening on your health plans. These are insured people. 60% of our diabetes-related expenditures are on complications and not on management of the disease. And obesity treatment is largely bariatric surgery and does not have a lot of the other pieces of this. So I'm looking at questions to see what's here. I'm going to move us to a poll question very quickly. Does your health plan offer first dollar coverage, pre-deductible coverage for diabetes management? So this is not just rebate pass-through. This is, anything for diabetes management can bypass the deductible. It is legal to do this. Some of you may be scratching your heads going, I've got a high deductible health plan. I'm not allowed to do that. Well, the reality is you are allowed to do that. The IRS has come out and said chronic disease management can be done pre-deductible, but you actually have to design the plan that way. You actually have to proactively tell your third plan administrator, whoever you're dealing with, to in fact do it that way. So I urge you to, let's see what we got. Again, 7%, only 7% are bypassing the deductible for chronic disease care or diabetes care. I really urge you to rethink that. 37% know you're not doing it, and 57% don't know. And again, take a look. This is an opportunity to lower your risk in a very dramatic way. So key plan design features that we've been covering here: first dollar coverage, bypass that deductible, get to a copay immediately on maintenance medications and therapies that you don't want the patient to stop taking. Certainly, in the first 3 to 6 months of the year, you want them adhering to therapy all the time. That's the primary message here. Rebate pass through, eliminating list price exposure, de-link the patient, your participant's cost from the list price of that drug. Share the plan discount with your people, just as you do with doctors' offices, hospitalizations, lab costs. Share that discount with your people. They'll thank you for it. Generics and biosimilars, make sure that you're covering them. Make sure that they are on your plans. And you say, how do I do that? The answer is talk to your pharmacy benefit manager and make sure you're dealing with one that is dealing in your best interest and your employees' best interest. There are PBMs out there that will do rebate pass-through, that will do first dollar coverage, that will do generic and biosimilar immediately, and allow the whole mix of coverage and care. Urge you strongly to treat that PBM as a vendor. If that J&J lawsuit gets legs, which I frankly believe that it will, because I think there's going to be several of these, you're going to need to do that just so that you protect yourself from personal liability in the future on this. I don't want to be a harbinger or a scare tactic, but as a plan administrator, I want to make sure I'm doing everything right from a compliance perspective, and I don't want to be run afoul of a ERISA law. There's a lot of things that are going. A lot of companies are looking at first dollar coverage. A lot of why are they doing it? They're doing it because they want to, for the sake of their employees, for employee retention. One thing I didn't mention in the obesity, anti-obesity medication side of things, that is going to be an employee retention tool as that goes on. We got a lot of discussion, and we actually hold webinars just on obesity, and I urge you to take a look for one of those where we get into the obesity discussion a lot deeper as to where that ROI is, where are we, but it is on most employees' minds today. I think there was a recent study that said 1 in 8 Americans, adults, have been taking a GLP-1. So urge you to take a look at that. We have plenty more plan options to look at. Hit our website. Please use the QR code. We're at the bottom of the hour, or top of the hour, I guess, and I'm going to have to sign off. But we've got a lot of things to talk about as far as telehealth, insurance literacy, continuity care, generic spread. If you please download the slides and look further. We probably don't have time for this, but as you're putting up there, are you more likely to consider passing rebates through at point of sale as a result of this conversation? I hope you'll say yes to this, but I don't want to lead the witness. But that's really a question of, from an educational perspective, has this made you think about it? And while you're answering, I just want to say thank you again for your time and attention today. I hope you got something out of this program that you can be thinking about as you go talk to your folks. So 57% said yes, 35% are unswayed, and 9% are already doing it. So interesting. I would urge the 35% to stay engaged in this discussion. There's a lot of areas where you're increasing your own risk, and as things go on. We're at Q&A, but we're really at the top of the hour. So thank you so much for your time. You can get the deck on our website. And again, I appreciate everybody's attention.
All right. Thank you so much, George, and to all of the presenters today. We thank you very much. And for your attendees, thank you for taking the time to meet with us for such a very important discussion. And to the folks at Diabetes Leadership Council and JDRF for sponsoring, we thank you very much. There's a question there. If the slides are available, yes, they are available on hr.com. If you have come late, this is recorded just now. It will be archived shortly on hr.com. And in that same place in the archives, you can also access the slides for the webcast. Your HRCI and your SHRM credits, those will be in your account within 2 business days. So just take a look for an email from hr.com with that. And most importantly, I have put a link to an exit survey in the chat. When I close out the session, it will pop open on your computer. Your feedback is important to us at hr.com, the folks at JDRF and Diabetes Leadership Council. So just take a moment to fill that out. Again, thanks, George and team. Take great care, everyone.
Thanks, everybody.